Hello, good afternoon, everyone. My name is Sadiq Bhayani. I'm a consultant staff in pain management at Cleveland Clinic in Abu Dhabi. I worked as a consultant in pain management in University Hospital Leicester and moved from UK to UAE back in 2023. First of all, I would like to thank the organizing committee of Welsh Pain Society for the opportunity to present on this topic, which I thought is a very broad topic, but I'm going to try my best to give you guys some golden nuggets and tell you what's upcoming and what's the innovation that's taking place in the field of pain management. Uh, and so let's go through this quickly. So nothing to disclose with regards to the presentation. I work here in Cleveland Clinic in Abu Dhabi, which is a really great institution. We have an interventional pain management center. So if anybody wants to visit us for observership, we are very open. I'll leave my contact details at the end, so you can drop me an email and you can come and observe our practice. We do have observers from all over the world, and Abu Dhabi is a great place to visit. So I do have other disclosures that I wanted to just disclose here is I'm a certified interventional pain sonologist. I'm a fellow of interventional pain practice. When I was in Leicester back in 2015 to 2022, we have ran multiple workshops and we founded Leicester Pain Education back in 2015. I'm a founder for Pain Talks, founder for Pain Flicks. I'm an editor for Nisora's Ultrasound Pain app and the recently published Ultrasound Pain Manual. And I work as an examiner for SIPS and FIP exam for World Institute of Pain. And I also worked as an immediate past clinical lead for E-Pain, Faculty of Pain Medicine, Royal College of Anaesthetists. So these are the logos for Pain Flicks, Pain Talks, and Leicester Pain Education. And this is the recent publication, a project of mine that we delivered in July 2025. The manual was published and it's available on Amazon and Google. And this is the ultrasound pain app, also on the Nisora's platform, New York School of Regional Anesthesia platform, and it has more than 30,000 downloads. It has multiple videos, lots of great illustrations, reverse ultrasound anatomy. So check this out. So, with regards to the today's topic, the innovation, the traditional methods of providing pain relief include giving medications, doing nerve blocks, epidurals, sending them for physical therapy, psychology, and cognitive behavioral therapy-based pain management programs. But we do know our medications, the nerve blocks, and the epidurals do have kind of downside to it. Medications do have side effects. There's a large number to treat. And the patients don't like continuing these medications, and there's a compliance issue. Also, there's also issues of addictions and dependence. In addition to that, when we perform the nerve blocks, sometimes the nerve blocks do last only for a short duration period. We do use corticosteroids, which can also cause long-term side effects if the steroids are given repeatedly in a short period of time. Also, with regards to the procedures, the nerve block may work in one person's hand, but it may not be successful in the other person's hand. So it's operator dependence. That's kind of, very important to consider. And there are variable outcomes. So when we talk about the innovative approaches in pain management, the innovation drivers are we do have this buzzword called precision medicine, and there's a lot of work going on in regards to providing precision pain medicine. Also, there are lots of advances that are taking place in the imaging world, and lots of different modalities are coming in the field of pain management. So we're going to talk about advances in interventional pain management because I'm an interventional pain physician, and I'm going to give you guys a flavor about the interventional pain management side of things. And also, we are living in the world of artificial intelligence and digital health. So we're going to talk about the digital health and AI. So innovations in interventional pain management, the drivers are every time you want to do an interventional pain management, the first important bit you want to consider is the accuracy of hitting the target. So if you're injecting a bursa or a nerve or a muscle or a joint, you want to precisely target that area. Second important bit that's considered which is of very prime importance, is safety. So as a doctors, we get taught first do no harm, primum non nocere. So, using the imaging modality that allows us to be safe and allows us to precisely target the area is important. Also, the interventions that we provide to the patients needs to be cost effective. They need to be easily reproducible. They there are also training needs, and these interventions, if you teach them to someone, they need to learn that appropriately, and they need to be reproducing that in their clinical practice. And these interventions need to be effective. So when we consider interventional pain management, I think these are the innovation drivers. So what we're going to talk about the in innovations in interventional pain management practice are advances in image-guided techniques. So we're going to talk about the ultrasound mainly, advances in modalities. We have been doing nerve blocks with local anesthetic and steroids, and off comes the radiofrequency treatment. But now we have also availability of cryoneurolysis, which is another treatment modality. So we'll talk about that. We'll talk about advances in regenerative medicine therapies, neuromodulation, as well as advances in minimally invasive spine intervention. So let's start with the image guidance. So, about 60 to 70% of interventions that I perform in my practice are ultrasound guided now, because ultrasound offers you a lot of advantages. It affords you the real-time visualization of the soft tissues, vessels, and nerves. On contrary, when you're using the X-rays, yeah, X-rays is a great modality of imaging, but it doesn't allow you to visualize the soft tissues, nerves, or vessels. Uh, the other important factor that ultrasound allows is greater accuracy and minimal complication. For example, if you're injecting a hip joint using ultrasound, you could see the lateral femoral circumflex artery branch, and you can avoid the hematoma or bruising in the groin because you can avoid the damage to the vessels. On contrary, if you're using just the X-rays, unfortunately, you might just go through the vessel and the patient may develop hematoma or bruising in the groin. So the complications can be minimized using the ultrasound technique. And it's portable, it's radiation free, and given that we as a pain physician, if we are using X-rays, we have to make sure we take care of the radiation protection side of things, and minimizing the radiation should be the aim. Now, I've chosen a couple of anatomical areas where I think ultrasound has been a game changer. So cervical spine is one of them, and these are the questions I always ask. If you're using any imaging modality, few questions you would ask like, okay, can ultrasound accurately identify the cervical level? Can ultrasound show the soft tissue structures and nerve roots? And can ultrasound increase the safety and accuracy? So moving on to the first intervention, that's been basically a game changer in the cervical region, using ultrasound guidance is a stellate ganglion block. We call that. It's actually a cervical sympathetic trunk, and we put the injection in the middle cervical sympathetic level, and the local anesthetic corticosteroid mixture would flow down to the C7T1 level, blocking the stellate ganglion, because stellate ganglion is located at C7T1, but we perform the injection at C6 level. Also, another intervention that has been safely performed is the cervical extraforaminal injection using the ultrasound guidance. And we're going to have a look at a few images to kind of give you more detail about this. Now, counting the level using the ultrasound guidance, you can precisely know which level you're targeting using the ultrasound. So C6 and C7 is the way we could actually start counting the level. C7 doesn't have anterior tubercle, it's only posterior tubercle, and C6 actually has an anterior and posterior tubercle. So here it is, the image of the C6 nerve root, where you would see here my pointer showing anterior tubercle and posterior tubercle. And here we have a nerve root quite clearly seen, and the needle coming in, stopping at the level of posterior tubercle. And here you can perform an extraforaminal injection, which gives a transforaminal spread. The beauty of this particular image is it's very consistent at the level of C6, C5, and C4. But when you move, so I'm just sort of, overdrawn this. So at the level of C6, it looks like a ghost buster. Basically, it's like a head of the ghost, anterior tubercle, and the posterior tubercle. Ultrasound is all about the imaging pattern recognition. More you look at the image and more you associate the image with something that you already know, more you better remember it. At the level of C7, we call it as a lounge chair position. So you have a posterior tubercle and you don't have an anterotubercle. And here we have a vertebral artery, which you can clearly visualize using the ultrasound guidance, and the C7 nerve root, which is also clearly visualized. And this is an intervention where you can avoid damage to vertebral artery or vertebral vein if you're doing a real-time ultrasound guidance and needling of the C7 nerve root. And this is what just showing you the cell out of the bone, showing the posterior tubercle with no anterotubercle at the level of C7. So just putting both of them together, C7 posterior tubercle, C6 anterior tubercle, and posterior tubercle with the nerve root in between. So as I say, stellate ganglion block was in the past performed using X-ray guidance, but with the recent advanced technology like ultrasound, people are moving away because stellate ganglion is a soft tissue structure, and the X-rays don't show you the soft tissues; they're only showing you the bone. So is the technique validated? And this was a study that was performed, the cadaveric studies performed in Canada by Mike Gofield and Anuj Bhatia and colleagues. And what they did, the ultrasound guided injection in the cervical sympathetic trunk, and they dissected the cadaver, showing the methylene blue dye staining the prevertebral fascia, deep cervical fascia, and accurately targeting the cervical sympathetic chain. Now, I put these two images. This was done in the past where people actually went at the level of C7, and then they put in the needle next to the tubercle, Shakniak tubercle, and they basically injected the dye and looked at the spread of the dye. But now you can perform the same intervention using the ultrasound guidance. You have longus colli muscle, and this is a spread in the longus colli muscle that you looked for. So longus colli muscle, you have middle cervical sympathetic ganglion, that's the longus capitis muscle, and here you can real-time ultrasound guidance, you can see the spread of local anesthetic. Now, why to use ultrasound? As I said, ultrasound not only just shows you the soft tissue structure, it also shows you important structures like blood vessels. And here we have inferior thyroid artery, which you will clearly miss if you're just using X-ray guidance to perform the stellate ganglion block. But you can clearly see this along with the vertebral artery and vertebral vein. And I call neck as a tiger territory. There are so many small blood vessels, and you can basically use ultrasound to accurately place the injection treatment and improve the safety. Other important structure, which is a soft tissue structure when you're performing stellate ganglion block, is the esophagus, which you can clearly see with the ultrasound guidance, but you will miss that if you're using the X-rays. And when you ask the patient to swallow, you will be able to kind of see what I call as a flash sign when the saliva basically gets kind of down the esophagus. So it's very clearly visualized using the ultrasound guidance. So advantage of using ultrasound guidance for cervical sympathetic chain or stellate ganglion block, you can accurately place the needle. You can visualize the sympathetic chain and deep cervical fascia. You can visualize esophagus, inferior thyroid artery. You can place the injection under real-time ultrasound guidance, and it sort of improves your success rate and minimize the complication. Given that we live in the world of Facebook with like buttons, so if you ask me, I would say ultrasound. I would give a thumbs up to the stellate ganglion block as a procedure to perform. Cervical nerve root block, as I said, is another intervention you can perform accurately using the ultrasound guidance. Now, why to use ultrasound guidance? Because if you put a color Doppler, you can actually pick up all these blood vessels. These are the radicular arteries that are feeding the nerve root, and you can, precisely avoid damaging them. The difference between X-ray and ultrasound: in X-ray, you will put the needle in, then you will inject the dye, and then you will do the X-ray. But your needle is probably already damaged the blood vessel, and the dye is going to run off. If you use the ultrasound, you're going to locate those blood vessels beforehand, and you will prevent the damage. And we know sometimes the spasm of the cervical radicular arteries is the reason that patients have developed cervical spinal cord ischemia, and that has been a kind of a disastrous complication of cervical transforaminal epidurals. So cervical nerve root blocks, they are feasible with the ultrasound. The extraforaminal injections may produce transforaminal spread, and that's a good way to kind of perform the injection treatment. So another like for the cervical selective nerve root block or extraforaminal injection. Can you do a transforaminal injection with the ultrasound guidance? Ultrasound is providing a 2D image, not a 3D image. So essentially, you're not putting the needle in the foramen, inside the foramen, you're putting it outside the foramen. So you're not doing a transforaminal epidural. Another good intervention where you can consider ultrasound is the sacroiliac joint. And sacroiliac joint pain is a combination of the ligament pain as well as the joint pain. And here just showing you the ultrasound image on the top when you put the ultrasound probe in the middle, you will see the sacral crest, medial sacral crest, and you will see the dorsal interosseous ligament, which are also a generator of pain, which you can inject using ultrasound guidance. And then showing you when you move the ultrasound probe down, you can basically see the upper part of the sacroiliac joint. Moving down, you can inject this area as well. And then moving down to the S2 level, where you will see a true sacroiliac joint. Here we have lateral part of the sacrum and the ilium, and you can inject the joint accurately using ultrasound guidance. Now, why to use ultrasound guidance instead of X-rays? Pregnant patients do get sacroiliitis, and you don't want to use the X-rays because you want to minimize the X-ray exposure to the fetus and the mother. So I think using ultrasound is a great advantage. It allows you to do real-time check of your injected. You can inject both ligament and the joint with the same needle entry. So this is another good intervention to do under ultrasound guidance. So sacroiliac joint injection, I would give a thumbs up. Caudal epidural, people have been using X-rays for caudal epidural, but ultrasound is a very kind of an elegant technique where you can actually put the ultrasound on the top of the sacral conua, and you will see both the sacral conuas along with the sacrococcygeal membrane and the anterior part of the sacrum. This is the transverse view. You can turn the ultrasound probe and you can get a longitudinal view. And the beauty is you can sometimes pick up the blood vessels as well in the caudal space. And this is just showing you a cartoon where you are bringing the needle in plane using the ultrasound guidance, getting into the caudal space. So the advantage of using ultrasound for caudal epidural, it helps to reduce the number of needle passes. You can accurately target the caudal space or entry to the caudal space, allows a small gauge needle, improves the patient's compliance. Calcification of the sacrococcygeal membrane can be picked up. Sometimes it's impossible to get the access to the caudal space because the sacrococcygeal membrane is calcified, and you will try X-rays and you'll not be able to get through. But if you use the ultrasound, you will be able to pick up this calcification, and you can avoid the intervention altogether. But unfortunately, using ultrasound solely doesn't rule out the vascular placement of the needle. You might be able to pick up the bigger blood vessel, but if there are smaller blood vessel, you will still have to use a hybrid technique, what I call combined ultrasound and fluoroscopy technique. So only ultrasound, no. Ultrasound and fluoroscopy, yes. And the dye also helps you to know how the dye is spreading. Is the dye spreading anteriorly into the sacral nerve roots, or is the dye spreading high up towards the sacrum, L5S1 level? If there is a pathology at L5S1, that's where you want your injected to go. So use fluoroscopy and ultrasound guided technique. So this is the kind of last slide on the imaging section. So the take-home points for the ultrasound imaging is it's a very useful modality of imaging for interventional pain management. It allows a real-time advancement of the needle, allows you to kind of reduce the complications like vascular puncture. The learning curve is slow and steep. Training is very important, and that's why you need to scan, 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 and that's the only way you will be able to learn ultrasound. And it's a definitely useful intervention. It's definitely useful imaging modality for interventions where you're looking at the soft tissues, for example, stellate ganglion, piriformis injection, or if you're doing any ligament injection. Moving on to the next bit of the interventional pain management is the modalities like radiofrequency and cryoneurolysis. So when we do injections with local anesthetic and corticosteroids, yes, they do work, but the longevity of pain relief is small. You want to increase the duration of pain relief, and that's where the modalities like radiofrequency and cryoneurolysis can be helpful. Now, we do know radiofrequency uses electricity, which leads to the heating of ions, leading to kind of heat generation, and then that what actually denaturates the protein around the nerve. So we do know the types of radio frequency. We have conventional radio frequency where you raise the temperature to 80 degrees for 90 seconds or up to 120 seconds. Pulse radio frequency where you're sending the electricity in pulses with a pause, and usually the temperature doesn't reach beyond the 42-degree mark. And the cool radio frequency, we're using the water cooling the tip of the probe, allowing the lesion to get bigger. On contrary, cryoneurolysis, we're using the gas to create the ice ball, and we're going to talk about that more in detail in the next few slides. So moving on to the radio frequency side of things, we do know bigger the needle, better it is. in terms of the size of the lesion. And that's what the research papers have showed us. So here we see the difference. We have the 23 gauge and 16 gauge. So bigger the needle, larger the size of the lesion. Look, the width of the lesion is 5.4 millimeters here, and the twice the size, 9.4 millimeter, if you use a 16 gauge needle. Same thing with the length. If the exposed tip also decides how big the lesion is going to be. And here we have a bipolar positioning of the needles. So if you have positioning of the needles close to each other, you will get a good lesion. But if the needles are very much spaced away from each other for more than a centimeter, or 1.5 centimeter level, then unfortunately you only get two individual lesions. So when you're performing radio frequency, it's very important to consider which nerves you're targeting and what's your needle size and what's your exposed tip. Is it 5 millimeter or 10 millimeter? We also know when we use cool radio frequency, because you are not allowing the tip of the temperature tip, tip of the temperature uh, to go beyond 60 degrees, it allows a larger lesion, and this is the forward projecting lesion, and that's the difference between a conventional radio frequency where the lesion is around the needle, and cool radio frequency, the lesion is actually forward projecting. Having said that, these are the recent innovative devices that have come out in the market, which are kind of in a good way to provide pain relief by providing a bigger lesion. These are the trident cannulas where the cannula opens up, creating a good bigger size lesion like cooled RF. We also have needles which are very nicely visible under ultrasound guidance. This is the kind of sono cannulas. And then we also have catheters where you can actually perform pulse radio frequency treatment in the epidural space, where you can put the needle, you can put the catheter in, and you can provide the pulse radio frequency to the nerve roots. So these are the advantages that have kind of, the not advantages, the innovations that have taken place in the field of radio frequency. Now, from heat, we're going on to the cold. So cryoneurolysis is all about cold. We're not talking about cryotherapy. We're talking about cryoneurolysis. And what is cryoneurolysis? You're using a gas which is basically expanded at the narrow tip, leading to the reduced temperature, and the temperature can go all the way down to -20 to -40, leading to axontomosis, leading to cryoanalgesia. So cryoneurolysis is the actual terminology, or an appropriate terminology that should be used. And how does it work? It works on Joule-Thomson's effect, the primary FRCA question in physics. So when you have a compressed gas that expands at the tip of the needle, it reduces the temperature, and the temperature can go down to -70, but at the tissue level, the temperature will go down to -20 to -40. Now, what it does to the nerve, it does cause what we call is a second degree nerve injury or axontomosis. So you're not affecting the nerve architecture, you're only causing axontomosis. And the beauty is this is completely reversible. So you have this immunofluorescence staining of the neuron pre-cryo, and then you have post-cryo, and then you see at C, which is the 32 weeks, the whole nerve has regenerated. So it's a completely reversible process. So cryoneurolysis, and this is the slide showing you the at 0 seconds, 15 seconds, 30 seconds, 60 seconds, and 90 seconds. Look at the size of the ice ball. This is around a 1 centimeter big ice ball that you can create using a 16 gauge, 18 gauge cannula. And what's in the device? So basically, the device has a kind of a touch screen. What inside the device is a gas cylinder which is attached to the device. You have a gas flow monitor, the thermistor to monitor the temperature, and you also can do stimulation like sensory stimulation or motor stimulation to know that you're close to the nerve. And then you also have a timer that allows you to do a defrost cycle. So the freezing cycle and defrosting cycle. On an average, the freezing cycle is around 3 minutes, and defrosting cycle is around 1.5 minutes. And I think that's been shown to provide good benefit in long run. And here I'm using the cryoneurolysis for the shoulder joint, doing the cryoneurolysis of the lateral pectoral branches to the acromioclavicular joint and the anterior part of the joint capsule. And this is the cryoneurolysis of the suprascapular nerve articular branches. We also use this for the knee joint, and this is a patient who actually had a pacemaker in situ, and I wanted to avoid using radio frequency. in order to just minimize the interference with the pacemaker device. So we performed cryoneurolysis of the superomedial. Here you see the cryoprobe going through a cannula, and this procedure was entirely done using ultrasound guidance. And we're doing the inferomedial genicular nerve cryoneurolysis for the knee joint pain. And this is the inferolateral genicular nerve cryoneurolysis, where you see the cryoprobe being placed under ultrasound guidance on the lateral part of the knee joint. So that's the advances in the modalities. The next bit is the advances in the regenerative therapies. And we've been injecting corticosteroids, local anesthetics in the joint, and there have been a lot of research about the cytotoxicity of the injectates that are being put into the joints. And I'll show you a couple of papers later on. But when it comes to, instead of basically injecting local anesthetic and corticosteroids, the focus is now shifting. The focus is now basically regenerating the damage, regenerating the cartilage, regenerating the ligaments and the muscle tissue. And that's where the role of regenerative therapies have come in. And most popular is the platelet-rich plasma therapy, which is autologous treatment, where you're taking the patient's blood, spinning it down, and you basically get a concentrate of platelets, which has high growth factors, and you inject it back into the patient. And image guidance has been a game changer. Using ultrasound or fluoroscopy guidance, you can target the area accurately, and you can inject the PRP where it needs to go, improving the precision and the efficacy of the treatment. The other new frontier in the regenerative therapy, stem cell therapy, where people are taking a bone marrow or adipose derived stem cells and injecting them into the damaged tissues in order to promote tissue repair and reduce the inflammation. So PRP is well known. And what is PRP? As it says, platelet rich plasma. So it's as a platelet concentrate. You're increasing the count of platelet, and essentially indirectly you're increasing the quantity of the growth factors that the platelets have. Now, this is the basics for PRP. The whole blood, we have plasma of 55% and a cellular component about 45%. Out of that, maximum numbers are red blood cells, you have nucleated cells, and the platelets only 2%. But when they spin down this whole blood, you will get platelet poor plasma, and then you will get what we call a buffy coat, where you have platelets with some white blood cells. So that's a platelet rich plasma. And this is what is your solution of choice to inject it back into the patient. And when we inject PRP, what you essentially doing, injecting growth factors, and platelets have alpha granules, which has multiple growth factors. You have vascular endothelial growth factor, epidermal growth factor, connective tissue growth factor, platelet derived growth factors, and you have dense granules, which has histamine, calcium, ADP, and serotonin. But we're interested in the alpha granules because of these growth factors. The tissue will regenerate. So potential benefits of PRP: it's autologous. It's basically kind of less immunogenic, or essentially it's not immunogenic. It doesn't mount any immunogenic response. It provides full array of naturally occurring growth factors, enhances angiogenesis, and also improves the collagen content. And there are lots of studies where they've done MRI, serial MRI scanning of patients having rotator cuff tear injected with PRP, and the cuff rotator cuff healing nicely over a period of few weeks. Now, when I was talking to you about the corticosteroids for the knee joint, this is a good paper to read on the cytotoxicity of drugs injected into the joint. Now, we do inject local anesthetic, and if you have orthopedic surgeons, or if you're using bupivacaine as a local anesthetic in the joint, my advice would be move out of that use of bupivacaine as a local anesthetic of choice, because bupivacaine is highly chondrotoxic. The least chondrotoxic local anesthetic is ropivacaine, but ropivacaine is expensive. So the midway between the bupivacaine and ropivacaine is lidocaine. So lidocaine is also a less chondrotoxic agent. But there was another study that was published in JAMA, the effect of intra-articular triamcinolone versus saline on cartilage volume. And what they realized, injecting the triamcinolone over a period of 2 years as compared to saline, resulted significantly greater cartilage volume loss. So if you are injecting corticosteroids in the patient joint, unfortunately, you are reducing the cartilage volume. And what essentially that's doing, they're going to buy the total knee replacement way earlier than what they would do if you don't inject the corticosteroids. So then went on to many PRP studies that came out, and that came out with an editorial. A time has come to try intra-articular platelet-rich plasma treatment for younger patients with symptomatic knee osteoarthritis. And this is a very good paper. So there's a huge uh, amount of good quality randomized control trials backing this up. So if somebody has a knee osteoarthritis, then PRP should be a treatment of choice. Uh, Now, where can you use PRP? Any part of the body, PRP can be injected. The evidence varies. There's a good amount of evidence in the knee, good amount of evidence in the hip, shoulder rotator cuff. There's a good amount of evidence. Spine, the evidence is equivocal. The sacroiliac joint also, the equivocal. Elbow, medial and lateral epicondylitis, there's a good amount of evidence supporting its use. So indications, you have acute indications. This is basically in the sports world, sports medicine. People do PRP for Achilles tendon, rotator cuff, medial collateral ACL tears. But in chronic pain side of things, for arthritis, tendinopathies, Achilles tendon, tennis elbow, patellar tendonitis, and plantar fasciitis. So PRP or stem cells is another, new innovative approach to the pain management. The next one is the advances in the neuromodulation world, the spinal cord stimulation, the dorsal root ganglion stimulation, and the peripheral nerve stimulation. Now, SCS is not new. SCS has been known, but there are a lot of new waveforms that have come up. This is a closed loop system that allows the stimulation to be adjusted based on the feedback. There is also high frequency 10 kilohertz paresthesia free waveform, and there's a burst stimulation which mimics a natural firing for better tolerance of the patient. And now they're combining high frequency with the burst, which is also currently a talk of the research in the field of neuromodulation. When you talk about the DRG stimulation that targets the dorsal root ganglion, which is a holy grail for pain management, we know the dorsal root ganglion is something that should be targeted, and you can precisely target that using the DRG stimulation, which is quite useful for patients with post-surgical pain or complex regional pain syndrome. For peripheral nerve stimulation, the advantages are you're only targeting one nerve, and essentially you can accurately target this with the ultrasound guidance. The newer hardware is very small, and it relies on the external power system. So this is the lead for peripheral nerve stimulation. It's like a small thread where you have this lead with the anchors, and this is basically the electrode where you will kind of put the patch on the skin, creating a full electric circuit, allowing the stimulation to be delivered to the nerve. There are many devices that are available. This is a temporary system, which is a 8-week system where you can put a lead in and you can stimulate the nerve for 8 weeks. This is a permanent system. This is another system which is permanent with the lead here and the receiver here. So many devices have come in, and this is just a picture showing the suprascapular nerve being targeted along with the axillary nerve being targeted for peripheral nerve stimulation. So moving on to the next topic, which is the invasive spine, minimally invasive spine interventions. Basivertebral nerve ablation has been kind of, recently been introduced for vertebrogenic pain. So patients who have modic changes, they are the one who suffer with chronic low back pain, and you could target the basivertebral nerve ablation. There are also applications of interspinal spaces for the patients with stenosis. Also, endoscopic discectomy and rhizotomies are gaining the traction in the field of minimally invasive spine interventions. So this is just showing you the picture of basivertebral nerve ablation. So it's the approach through the pedicle, ablating the basivertebral nerve. Moving on to the last bit of my talk is the digital health and AI, and we are living in the world of artificial intelligence, and AI-driven pain prediction models have been, recently been studied using the patient data, using variables to anticipate the pain flare-ups, and essentially that can help to combine with neuromodulation device where the targeted therapy can be delivered. Mobile pain tracking apps are there, combining behavioral data, biofeedback, and adaptive pain coaching. There are also digital cognitive behavioral therapy apps that are out there, allowing people to access the pain management program using the cognitive behavioral therapy approach. Now, when we talk about digital health, virtual reality has been another digital revolution in the field of pain management. This is a virtual reality related documentary that was on the BBC. FDA has also authorized virtual reality system for chronic low back pain. How does the virtual reality work? So virtual reality immerses the patient in a computer generated world. It's basically hijacking the pain. It's like a distraction therapy. It drains the brain of neural resources by occupying the brain environment. So we call this a cognitive load. So if you occupy the brain using the visual and auditory stimuli, you will reduce the pain processing, and that's what it says. It reduces the input to the somatosensory cortex. So brain is left with less attention to process pain signals. So simple analogy, virtual reality is like a syringe. Your program that you're putting in the virtual reality is like a drug in the syringe. More the interactiveness, more the senses that are involved in the virtual reality, more the powerful effect of the virtual realities. And virtual reality is basically equivalent to distraction, mindfulness, CBT. So there are many, many applications of virtual reality. People have been using virtual reality for acute pain management, for post-operative setting, procedure-related pain management. So people, instead of giving them sedation, they're using virtual reality to occupy patients' brain whilst they're undergoing procedures or dressing changes. Chronic pain management, as I said, back pain. Patients have been using virtual reality to manage back pain. Cancer pain management, also rehabilitation setting. People are using the virtual reality, and this is me using the VR headsets, where this is the virtual reality game where you're actually picking up the apples from one basket and trying to put them in the other basket. And this has been used quite successfully in the rehabilitation world. So advantages of virtual reality, there are a lot of research papers out on virtual reality showing the reduction of pain scores, reduction of the opioid use, improved movements, aiding rehabilitation, reducing the stress, improved sleep, improved quality of life, and patients are not confined to the bed to get pain relief. They can get out and do the virtual reality session, and they can get good pain relief. So in summary, pain management is shifting towards precision guided therapies using appropriate imaging modalities like ultrasound guidance. New modalities like cryoneurolysis are coming up. You also have regenerative and biologic solutions like platelet rich plasma, stem cell therapies. Also, intelligent neuromodulation is a driving force now, as I showed you that new waveforms are coming up, providing better pain relief. Virtual reality and mobile phone applications are surging to provide data-driven, personalized pain management. So thank you so much for your attention. If you guys are visiting Saudi Arabia, do come and join us in Riyadh on 21st and 22nd of November, where we're running a masterclass. We do have cadaver courses we still run in Leicester through Leicester Pain Education Portal. It's going to be on 31st of Jan and 1st of February. We are running a masterclass on interventional pain management in Leicester. These are the website which can be very handy. The website called blockic.club is where you have PainFlex, and the proacademy.club. So the websites will have the details about the event. The other website which is quite useful is a bookcpd.com, where you'll be able to kind of register for these events. You can connect with me on LinkedIn. This is my LinkedIn portal, Sadiq Bhayani, and also on the Facebook. Thank you so much, and I hope you guys enjoy the rest of the day. Much appreciate. Thank you so much. Have a great evening. Take care. Bye bye now.